think we can start.
Yeah.
Yes, sir. Good morning, everyone. My topic today is lung cancer. So, the contents of my topic are as follows: clinical presentation, radiological evaluation, diagnosis and staging, surgical treatment, lymph node dissection, radiation therapy, adjuvant and neoadjuvant chemotherapy.
Before that, you should have included etiology of the lung cancer and the pathology of the lung cancer, because there has been a lot of changes from the IASLC edition 7 to edition 8, and now the edition 9 is coming up. The whole classification of lung cancer has been changed. You should talk about pathology, etiology, pathology, and then come to clinical presentation. Okay, anyway.
Yes, sir. Sir, since it's a very big topic, I thought keep it more clinical. That
No clinical, sir. You have to know what you're treating, sir. It is not clinical. You're just not going to cut somebody up. You have to
Yes.
know why you're cutting, what you're cutting, when you're cutting, how you're cutting, and when not to cut.
Yes.
It's not just surgery.
Yes.
And what are the prognosis? How do you manage? How do you decide on which mode of treatment for what type of cancer?
Local symptoms, symptoms from metastasis and paraneoplastic symptoms. So again, local symptoms can again be bronchopulmonary symptoms. Hello. Yes, sir. So local symptoms can be bronchopulmonary symptoms that are cough, hemoptysis, wheeze and stridor, and dyspnea and post-obstructive infections. Non-bronchopulmonary symptoms are pain, Pancoast tumor, and dysphagia. Others are pleural effusion, pericardial effusion, and superior vena cava syndrome. Symptoms from metastatic disease are symptoms from neurological mets, adrenal mets, bone mets, and liver
We are
metastasis.
not able to see your slides. It's all jumbled up. It's all jumbled up. I can't make.
Yes. So symptoms from metastatic disease, symptoms from neurological metastasis.
Move Dr. Jairaj's picture
Yeah.
out.
So, out of the piece. Yeah.
Yes.
Thanks.
Yeah.
Yeah.
Okay.
Yes, sir. So from metastatic disease, neurological metastasis, adrenal metastasis, bone metastasis, and liver metastasis. Then from paraneoplastic syndromes that can be divided into metabolic symptoms, neurological, skeletal, hematologic, cutaneous, and others. Uh, common, common presenting symptoms of lung cancer. Now, based on uh, the percentage of the percentage of each symptom present. Cough is present in 24 to 68%, dyspnea in 17 to 59%, hemoptysis is 5 to 41%, hoarseness of voice is 2 to 15%, chest pain in 5 to 64%, extrathoracic pain in 8 to 36%, neurological in 10 to 12, weight loss in 27 to 50%, anorexia in 19 to 64%, and fatigue in 8 to 68%. Coming to local symptoms, cough. Cough is the most common presenting symptom of lung cancer, but it is frequently overlooked because it is far more associated with infections or chronic bronchitis. Cancer associated cough is caused by airway irritation secondary to mass effect, inflammatory response to cancer, or mucin production or obstruction causing pneumonia. Smokers frequently have a chronic cough, but changes in character, sputum frequency, sputum production frequency of the cough should prompt further evaluation. There are no particular characteristics that distinguish benign from malignant causes of cough. However, cough associated with symptoms, weight loss, anorexia, hemoptysis, or laboratory abnormalities, spirometry, or thrombocytosis increases the likelihood of a cancer diagnosis. Hemoptysis. Hemoptysis is generally an alarming symptom that leads to rapid presentation to the medical system. Hemoptysis from lung cancer is generally small in volume, less than 500 ml in 24 hours. Possible sources of hemoptysis include systemic supply from the bronchial arteries or collaterals, pulmonary supply from the pulmonary artery or veins. Severe systemic arterial bleeding may be controlled by embolization. Carcinoma-induced hemoptysis frequently has a multi-source blood supply, and this compared with other causes of hemoptysis has reduced success of embolization. Survival after embolization for lung cancer-induced hemoptysis is less than 4 months. Wheezing or stridor. Lung cancer can cause airway obstruction and turbulent airflow, resulting in the harshness of stridor or musical wheezing. Both intrinsic obstruction by tumor mass and extrinsic airway compression by tumor or adenopathy may cause obstruction. Stridor generally indicates tracheal obstruction and occurs when more than 50% of the lumen is obstructed. Occasionally, central mainstem bronchial tumors may create stridor. Wheezing is caused by lung cancer in contrast to wheezing caused by lung cancer in contrast to polyphonic diffuse asthmatic wheezing is often monophonic and localized around the area of obstruction. Both stridor and wheezing from tumors involving the trachea are occasionally diagnosed as adult onset asthma. Stridor is an inspiratory noise and should not be mistaken for the expiratory wheezing of asthma. Neither stridor nor wheezing caused by cancer responds well to bronchodilators. Chest, chest radiographs are often unrevealing, but CT scanning will usually show intraluminal mass or extrinsic compression by tumor or adenopathy. Bronchoscopy is usually diagnostic when symptomatic airway involvement is present. Dyspnea. Lung cancer may cause dyspnea by multiple different mechanisms. Airway obstruction can cause atelectasis distal to the obstruction. Similarly, obstruction or compression of the pulmonary artery or branches may result in areas of defunctionalized lung secondary to hypoperfusion. Ventilation perfusion mismatch in either case may cause dyspnea. Post-obstructive pneumonia can similarly result in dyspnea. Additionally, tumor infiltration of lung parenchyma or increased lung water from inhibition of lymphatic drainage can result in increased alveolar thickness, less efficient gas diffusion, and relative shunting. Pleural effusions frequently cause dyspnea. Symptomatic effusions from lung cancer commonly contain malignant cells. Less common causes of dyspnea are phrenic nerve paralysis and pericardial effusion. Post-obstructive infectious symptoms. Tumors that obstruct airways inhibit airway drainage along colonization and overgrowth of bacteria. The resulting post-obstructive pneumonia can cause fever, leukocytosis, malaise, and weight loss. Chest imaging may be unable to reliably distinguish tumor mass from pneumonic process. Therefore, patients treated with antibiotics should have a follow-up radiography to confirm complete resolution of infiltrates. Recurrent pneumonia in the same location should prompt CT scanning and bronchoscopy to exclude intraluminal tumor or an anatomic basis for recurrence. Non-bronchopulmonary symptoms: pain, Pancoast tumor, dysphoria.
One sec. All these symptoms that you talked about are all common even for infective processes. How do you differentiate that from malignancy? So this is the reason why I told you that you should first talk about etiology. some pathological tumors are central tumors, some are peripheral tumors, and some may be combined. So, and then the presentation can be like a mass lesion, like a pneumonic consolidation, like an atelectasis. So clinical features, you have to talk about that. You know, you wanted to do clinical this thing, right? So how do you differentiate some? You got a mass lesion that is given to you in the exam, or even in your day-to-day practice. You have to know what it is. Either is it a infective process or a malignant process? If it is a malignant process, whether it is benign or malignant. And if it is malignant, what type of cancer it is? You have small cell cancer, you have non-small cell cancer. Out of the non-small cell cancer, you have 4 or 5 major varieties. So these are all things that you should know before you go on to these things, right? So that is why etiopathology and pathology of the thing is very important.
Yes.
All these can be in any lung condition. All these local symptoms that you talked about. Okay, go ahead.
Then non-bronchopulmonary symptoms are pain, Pancoast tumor, and dysphagia. Pain. Chest wall pain may bring patients to medical attention. Pleural-based pain may be due to direct irritation of the parietal pleura by either inflammation from post-obstructive pneumonia or by direct invasion of tumor. Tumor invasion or metastasis to ribs may create bone pain. Additionally, sensory nerve invasion, intercostal or brachial plexus, can lead to neuropathic pain. Chest wall pain in the region of known tumor should raise suspicion of chest wall invasion. Diffuse facial pain from lung cancer may be caused by invasion of the ipsilateral vagus nerve and relieved by treatment of the primary tumor. Preoperative evaluation should include imaging of the region to define depth of invasion and involved structures. When complex neurovascular structures are involved, such as the apex of the chest or spine, magnetic resonance imaging (MRI) can provide better anatomic definition than CT scanning. Operations on patients who have chest wall pain should include a strategy for en bloc chest wall resection. Pancoast tumor. Superior sulcus tumors may invade the brachial plexus and stellate ganglion, presenting with a constellation of signs and symptoms known as Pancoast tumor. Pancoast syndrome. These include ipsilateral Horner's syndrome, facial anhidrosis, meiosis, ptosis, as well as neuritic pain and muscular atrophy in the arm and hand. Horner's syndrome is caused by direct tumor invasion of the stellate ganglion. Tumor invasion of the local brachial plexus cord C8, C7, C8, T1 leads to inner arm pain and wasting of intrinsic muscles of the hand. Vertebral body or rib dissection results in bone pain. Direct invasion of intercostal nerves can also cause chest wall and inner arm pain. Although locally invasive, Pancoast tumors are frequently amenable to treatment with multimodality therapy, including surgical resection. This is a CT image of Pancoast tumor, sir, and on the side you can see course of the on the side you can see the sympathetic chains. Local symptoms. Dysphagia. Dysphagia occurs rarely as a presenting complaint of lung cancer. When it does occur, it is usually due to esophageal compression, invasion from subcarinal nodal disease, or tension hydrothorax. Rarely, direct extension of the tumor or involvement of paraesophageal nodes causes obstruction. Pleural effusion. Patients with dyspnea from lung cancer frequently have malignant pleural effusion. Typically, one-sided effusion results from an imbalance between pleural fluid production and resorption. Cancer patients may develop effusions from any of the following: increased capillary permeability or hemorrhage from tumor implants, decreased oncotic pressure from hypoproteinemia, decreased absorption secondary to lymphatic obstruction by tumor. Pleural effusions are associated associated with lung cancer can be reactive, especially in the setting of post-obstructive atelectasis or pneumonia. Thoracocentesis and fluid cytology is indicated to establish the presence or absence of malignant cells prior to resection. In a report of 860 pleural effusion specimens from patients without known lung cancer, cytology demonstrated lung cancer in 2%, i.e. 31 people. All died within 19 months of diagnosis, attesting the poor survival of patients presenting with malignant effusions. Pericardial effusion. Although tumor invasion of the pericardium is frequent in patients who die of lung cancer, it is rarely the problem. Lung cancer is the most common cause of malignant pleural effusion. Both exudative and transudative effusions may be caused by lung cancer. Pericardial seeding combined with lymphatic obstruction causes the accumulation of fluid. Bloody pericardial effusions are nearly always malignant. Very large effusions can develop if fluid production is relatively slow. This allows the pericardium to enlarge and accommodate the fluid without causing tamponade. Tamponade is usually
Excuse me, bloody pericardial effusion can be due to cardiac injury as well. So just because you have a bloody pericardium doesn't mean everybody has a malignancy. Isn't it?
Yes, sir.
You're a cardiac surgeon, man.
Yes.
Bloody pericardial effusion does not always, nearly always malignant is not a right sentence. Okay. Don't generalize things which are not right.
Okay. Tamponade is usually the result of rapid fluid accumulation or bleeding into the relatively indistensible pericardium. When tamponade is the initial presentation of lung cancer, it is associated with poor prognosis. Superior vena cava syndrome. In the modern era, lung cancer has replaced inflammatory diseases as the most common cause of superior vena cava syndrome. Symptoms include a feeling of fullness and swelling in the face and arms. Frequently, this worsens when the patient is recumbent at night and improves with head elevation. Distended neck veins and large superficial chest and neck collaterals may be present. SVC occlusion may develop insidiously as the SVC is slowly compressed and collateral pathways enlarge. In this situation, SVC syndrome may be mild or non-existent. Rapidly growing tumors or those that cause thrombosis are typically associated with worse symptoms because collaterals have insufficient time to develop. SVC thrombosis usually results from direct SVC compression by tumor or adenopathy. However, SVC invasion by tumor may directly obstruct flow and create an nidus for thrombus formation. SVC syndrome is rarely an emergency, and correct diagnosis of the underlying cause should be made to provide rational treatment. Diagnosis of the inciting cause usually involves obtaining tissue by needle biopsy, bronchoscopy, or mediastinoscopy. SVC syndrome caused by non-small cell lung cancer usually indicates unresectability. Symptoms from metastatic disease. Bone metastasis, neurological, adrenal, and liver metastasis. Bone metastasis. Lung cancer metastasis to nearly every bone have been reported. The axial skeleton and long bones are the most common sites. Metastasis to bones of the hands and feet are rare. Bone pain is the usual symptom. Pathological fractures occasionally herald the presence of lung cancer. Plain radiograph, bone scans, positron emission tomography, CT, and MRI may all be helpful in diagnosing bone metastasis. Nuclear medicine studies are sensitive but not highly specific and should be correlated with anatomic studies or biopsy or both. Lung cancer metastases are generally osteolytic, although some tumors do create osteoblastic lesions. Neurological symptoms associated with metastasis. The etiology of neurological symptoms is due to central nervous system metastasis, spinal cord compression secondary to epidural or vertebral metastasis, leptomeningeal carcinomatosis, hyponatremia secondary to SIADH, hypercalcemia, embolic infarction secondary to merantic endocarditis, embolic infarction secondary to tumor thrombi, thrombotic infarction secondary to disseminated intravascular coagulation or superior sagittal sinus thrombosis, intracranial hemorrhage due to coagulopathy secondary to tumor or treatment, central nervous system infections, paraneoplastic syndromes. Brain metastasis. Symptomatic brain metastasis from an unknown primary tumor frequently arise from lung cancer. Symptoms are generally caused by an increase in intracranial pressure, headache, nausea, blurred vision or diplopia, and change in mental status. Focal neurological deficits or pain due to meningeal or bony invasion are less common. The syndrome of inappropriate antidiuretic hormone may present secondary to brain metastasis. Although small cell lung cancers are most likely to metastasize to the brain, adenocarcinoma, because of the higher prevalence, has the highest incidence of brain metastasis. Both CT and MRI can be used to identify brain metastasis, but MRI is more sensitive. PT scans may be generally ineffective because of the high metabolic rate of background neurological tissue. Carcinomatous meningitis is a rare presentation of lung cancer. This most frequently develops in the course of small cell lung cancer. Symptoms include changes in mental status, seizures, headache, cranial neuropathies, weakness or secondary changes to bladder and bowel dysfunction, sensory changes, and back pain. CT scans are usually normal, but cerebrospinal fluid cytology is diagnostic. Spinal epidural metastasis occur relatively frequently in the setting of malignancy. External compression of the spinal cord or cauda equina causes back pain and radiculopathy or myelopathy. MRI is the most sensitive and provides precise anatomic information. CT-guided needle biopsy of the spinal lesion is generally successful. Because paraneoplastic and non-malignant processes may include symptoms similar to those caused by SEMs, that is spinal epidural metastasis, should be confirmed by the presence of by appropriate studies. Most metastases can be treated with radiation therapy. Surgical resection and reconstruction may be useful in cases of spinal instability due to bony destruction. Liver metastases are generally asymptomatic until very late in the course of lung cancer. Most commonly, they are found during staging CT scanning. PET scans are also effective at detecting liver metastasis and are helpful in differentiating malignant from benign nodules that are indeterminate on CT scans. Lesions that are hot on PET scan and visible on CT scan should undergo biopsy if the presence or absence of metastatic disease would modify treatment. Symptoms associated with liver metastasis include abdominal pain, anorexia, jaundice, ascites, hepatomegaly, and liver failure. Paraneoplastic syndromes in lung cancer, metabolic or hypercalcemia, Cushing's syndrome, inappropriate production of antidiuretic hormone, carcinoid syndrome, gynecomastia, hypercalcitonin, elevated growth hormone level, elevated levels of prolactin, follicle stimulating hormone, and luteinizing hormone, hypoglycemia, hyperthyroidism. Neuromuscular paraneoplastic syndromes are encephalopathy, polymyositis, autonomic neuropathy, Lambert-Eaton syndrome, opsoclonus myoclonus, gastrointestinal neuropathy, polymyositis, dermatomyositis, limbic encephalitis, cortical cerebellar degeneration, spinal cerebellar degeneration, dementia. Hematologic syndromes are anemia, leukemioid reaction, thrombocytosis, thrombocytopenia, eosinophilia, pure red cell aplasia, leukoerythroblastosis, disseminated intravascular coagulation, hypercoagulability, and hypocoagulability. Skeletal clubbing and pulmonary hypertrophic osteoarthropathy. Cutaneous and muscular hyperkeratosis, dermatomyositis, acanthosis nigricans, hyperpigmentation, erythema gyratum repens, hypertrichosis languosa equisita. Others are nephrotic syndrome, hypouricemia, secretion of vasoactive intestinal peptide with diarrhea, hyperamylasemia, anorexia, and cachexia. So, paraneoplastic syndrome frequently associated with different cancer types. SIADH is seen in 7 to 16% of small cell lung cancer, secretes ADH and causes mental status changes, lethargy, seizures. Then hypercalcemia is seen in 8 to 13% of squamous cell carcinoma patients. It is due to parathyroid related protein and typically is a marker for advanced disease. Cushing syndrome is seen in 1 to 5% of small cell carcinoid. Molecule responsible is ACTH and precursor molecules. Causes Cushing syndrome and features. Worse for both small cell and carcinoid. And, this is an image of clubbing, sir. And the second one is an image showing bone scan demonstrating hypertrophic pulmonary arthropathy. Radiological evaluation of lung cancer. So Garland estimated that when lung tumor is first detectable on chest radiograph, it has completed 3/4 of its natural history. Rigler observed that the radiographic abnormality frequently antedates the first symptoms or signs of the disease by more than 7 months. These early features are subtle and often appreciated only in retrospect. Early signs of lung cancer are as follows on chest X-ray. A focal opacity within the lung parenchyma, cavitary mass, segmental indistinct poorly defined opacity, nodular streaked local infiltration along the course of a blood vessel, segmental consolidation, a roughly triangular region arising in the apex and extending toward the hilum, mediastinal mass, an uncommon early sign, then enlargement of one hilum, segmental or lobar obstructive emphysema, also a rare finding in carcinoma of the lung, segmental atelectasis, pleural effusion, pericardial effusion, elevated hemidiaphragm. The radiographic findings caused by carcinoma.
You didn't mention the most important sign, speculated margin of a lung mass. Yeah, that is what gives you a clue on the radiology that this mass is a malignant lesion. That is a classical thing. A cavitary mass and other things are very rare, are much later. A speculated margin of the lung mass is the classical sign of lung cancer. Okay.
The radiographic findings caused by carcinoma of the lung may result from the tumor itself, from changes in the pulmonary parenchyma distal to the bronchus obstructed by the tumor, and from spread of the tumor to extrapulmonary intrathoracic sites, hilar, mediastinal lymph nodes, pleura, chest wall, and other mediastinal structures. The smallest single solitary lesion that can be seen is approximately 7 millimeters in diameter, although multiple smaller lesions, diffuse lung lesions, may be recognized. The single lesion is frequently not identified until it is more than 10 millimeters in diameter. A smaller lesion may be obscured by overlying or adjacent structures. Radiographic findings in 200 patients with lung cancer. So, tumor in the periphery of the lung was seen in 39.5% of patients. Hilar tumor in 19.5% percentage. Atelectasis in 13.5%. Pleural effusion in 7%. Hilar invasion 5%. normal chest X-ray in 4%, infiltrative shadow in the periphery in 3%, others 8.5%. Influence of cell type on X-ray findings. Certain radiographic patterns are characteristics of various cell types. Squamous cell carcinoma presents a picture of obstructive pneumonitis, pulmonary collapse, parenchymal consolidation because 65% of these tumors occur in a central location in the bronchial tree. A hilar abnormality is often present. Approximately 1/3 of squamous cell tumors appear as peripheral masses. Many are small lesions less than 3 cm in diameter. Cavitation is more common in peripheral squamous cell carcinomas than in other lung cancers, occurring in approximately 10 to 20% of patients with these peripheral tumors. This is an X-ray image showing uh, A is a posterior and B is a lateral image. Radiographs of a smooth, thin-walled carcinomatous cavity in a 43-year-old man with hypertrophic pulmonary osteoarthropathy with positive sputum cytology. The minimum wall thickness was 2 millimeters. Influence of cell type on X-ray findings: adenocarcinoma. Adenocarcinomas
This is a very unusual presentation of lung cancer. Extremely rare. This is not the common. You must understand, you must learn the commoner presentations and then go on to these rarer things. A thin walled cavity is very, very rarely malignant lesion.
Yes.
Okay, go ahead.
Adenocarcinoma. Adenocarcinomas are most often peripheral masses. As with the peripheral squamous cell tumors, a great percentage of these lesions are initially recognized when they are more than 3 cm in diameter. Many are still not discovered, however, until they are more than 4 cm. Cavitation is rare, and these peripheral lesions represent 60 to 70% of the primary adenocarcinomas of the lung. The lesion most often has a nodular or ill-defined border, a corona radiata as it was termed by Heitzman and colleagues, or sunburst appearance of the border, is often readily appreciated on the standard radiographs and may represent local lymphatic spread. Eccentric calcification may be present within the mass. A hilar abnormality or obstructive parenchymal lesion is less common than peripheral mass. Woodring and Stelling reported that 26% of adenocarcinomas presented solely as central masses, and 51% of all patients had some degree of central involvement, hilar or mediastinal node adenopathy. A subtype of adenocarcinoma, bronchoalveolar carcinoma, may present as solitary peripheral mass. It represents approximately 35% of all small peripheral masses. Localized area of pneumonic infiltrate may extend to involve the entire lobe or even more of the lung, or less commonly as multiple unilateral or bilateral coalescent multinodular infiltrates. Unlike tumors of other cell types, the presence of air bronchograms in the areas of involvement is common. Less frequently, an interstitial pattern of involvement of the lung is noted, which Berkman reported to be the result of secondary lymphatic spread of the tumor. Large and unassociated carcinomas are most likely to be peripheral. Approximately 60%. 2/3 of these are more than 4 centimeters. Cavitation occurs in approximately 6% of these peripheral large cell tumors. Hilar abnormality and parenchymal changes are each present in association with approximately 1/3 of these tumors. Small cell undifferentiated tumors appear primarily as hilar abnormalities, 78%, which usually represent hilar or mediastinal lymph node metastasis. These tumors are associated with mediastinal widening in 13% of patients, more than 13% of patients. In some of the patients with this finding, a parenchymal abnormality cannot be recognized. Parenchymal obstructive lesions occur in 40% of extrinsic compression of a bronchus in slightly less than 40% of patients. CT scan. CT scan has become a routine examination for patients suspected of having lung cancer. Like any other non-invasive examination, however, it cannot distinguish inflammatory tissue from cancer tissue. In central lesions, CT is useful for demonstrating enlarged hilar lymph nodes. The demonstration of enlarged nodes may suggest the need for a pneumonectomy as the surgical procedure. The caliber, distortion, thickening of the wall of the proximal bronchi can also be discerned. Involvement of the pulmonary vessels, even with contrast enhancement, is difficult to determine at times. In patients with peripheral lesions, the margins, presence of calcification, cavitation can be elicited. Weyrich and associates evaluated high-resolution CT in distinguishing malignant from benign peripheral nodules. They found that speculation of the borders, pleural tags, bubble-like areas of low attenuation were present in 87, 58, and 25% of malignant lesions, respectively. In benign lesions, these percentages were 55, 27, and 9% respectively. Thus, none of these criteria can be used as an equivocal sign of malignancy. So, this is a CT image, sir. Squamous cellular lung cancer versus lung abscess, comparing those two. Axial CT scan A shows coronal view, axial CT scan A and coronal view in the B. In a 70-year-old male patient with fever, cough, and chest pain for a few weeks, with laboratory tests showing infection and unresponsive to first-line antibiotic therapy. The presence of inner air fluid level, rim contrast enhancement, and clinical finding are suggestive for lung abscess. Then the second one, C and D, are in a 66-year-old male patient in the presence of air fluid inner level may be indicative of lung cancer, lung abscess, but the absence of clinical evidence of infection, thick walls, ground glass opacities in the surrounding pulmonary parenchyma, and small satellite pulmonary nodules are suggestive for squamous cellular lung cancer. The CT angiogram sign in patients with bronchoalveolar carcinoma. With contrast enhancement in patients with segmented or lobar consolidation, enhancing branching pulmonary vessels are seen as in areas of homogeneous low attenuation when the consolidation is related to presence of this tumor. Air bronchograms may also be seen. A ground glass appearance is typical of small peripheral nodules that are early bronchoalveolar carcinomas. This haziness is thought to be due to the lipidic growth pattern of these tumors. In addition, bubble-like hyperlucency or pseudocavitation representing patent airways can be present. With growth, areas of consolidation with high attenuation values may be seen. These areas represent the so-called scar or sclerotic areas within the tumor. This is a CT scan image showing left upper lobe. It shows a 4 centimeter nodular bronchoalveolar carcinoma with heterogeneous attenuation and a well-visible pleural tail sign. The next image is a CT scan that demonstrates a small nodule with spiculated margins surrounded by a large halo of ground glass attenuation, halo sign. The next one is it shows a bronchoalveolar carcinoma surrounded by a large halo of ground glass attenuation. Subpleurally, another small satellite nodule can be seen infiltrating a secondary pulmonary lobule. The next is a CT scan through lingula demonstrating a pneumonic-like zone of consolidation with heterogeneous attenuation. Small radiolucencies can be seen near the air bronchograms. So this CT scan shows a pneumonic-like lesion with well-demarcated mucoid bronchogram and the angiographic sign. This shows areas of this shows large areas of parenchymal consolidation with marked air bronchogram sign surrounded by a large halo of ground glass attenuation represented lipidic growth tumor. Intratumoral bronchioles, intratumor bronchioles, multiple pseudocavitations, and fine acinar nodules can be seen. Next, calcification. Calcification occurs in as often as 13% at the time of 13% of the time in lung cancer, as shown by Mahoney and co-workers in a CT study of the lesion subsequently proved to be cancer. This calcification is most often eccentric. Concentric laminated calcification on the middle of a mass, however, is virtually diagnostic of tuberculous or fungal granuloma, whereas diffuse calcification throughout the mass, popcorn calcification is the hallmark of a benign hematoma. The most important aspect of radiological diagnosis of lung cancer is that radiological studies alone cannot make the diagnosis. Definitive diagnosis can be made only by cytology or histology. So, staging, sir. TNM staging, primary tumor characteristics. TNM 8 staging, primary tumor characteristics are coming to the TX tumor in sputum bronchial washings, but not to be assessed in imaging or bronchoscopy. T0 is no evidence of tumor. TIS is carcinoma in situ. Now, T1 includes four subtypes. T1 is a tumor less than 3 cm in size, involving the visceral pleura and not involving the main bronchus. T1A MI is minimally invasive carcinoma. T1A is less than 1 centimeter, 1B is 1 to 2 centimeters, and 1C is 2 to 3 centimeters. T2 is 3 to 5 centimeter mass or involvement of the main bronchus without the carina, regardless of distance from carina, or invasion of visceral pleura, or atelectasis or post-obstructive pneumonitis extending to hilum. T2A is tumor less than 3 to 4 centimeters, and T2B is 4 to 5 centimeters. T3 is tumor 5 to 7 centimeters in greatest dimension, or tumor of any size that involves the chest wall, pericardium, phrenic nerve, or satellite nodules in the same lobe. T4 is greater than 7 centimeters in greatest diameter, or any tumor with invasion of mediastinum, diaphragm, heart, great vessels, recurrent laryngeal nerve, carina, trachea, esophagus, spine, or separate tumor in different lobe of ipsilateral lung. Nodes N1 is ipsilateral peribronchial or hilar lymph nodes and intrapulmonary nodes. N2 is ipsilateral mediastinal or subcarinal nodes. N3 is contralateral mediastinal or hilar ipsilateral or contralateral mediastinal or hilar ipsilateral or contralateral scalene and supraclavicular nodes. M is distal metastasis. M1A is tumor in the contralateral lung or pleural pericardial nodule or malignant diffusion. M1B is single extrathoracic metastasis, including single non-regional lymph node. M1C is multiple extrathoracic metastasis in one or more organs. Now, differences between TNM 7th and 8th edition. In the T1A is less than 2 centimeters, 1B is 2 to 3 centimeters. Here it is changed to T1A less than 1 centimeter, T1B 1 to 2 centimeters, and 1C 2 to 3 centimeters. Then
Why this change? Why this change came about?
Tumors less. Why this change came?
How much difference will it make from 1 centimeter to 2 centimeters on clinical or radiological examination? But why did they change it into 1A, 1B, 1C, 2A, 2B? What was the reason for doing this? No idea.
No, sir.
It was meant for prognosis. When you have less than 1 centimeter, the prognosis is much better than 1 to 2 centimeters or higher up. So that is why you had to look at the survival pattern of all these things, T1, T2, T3, and then 1A, 1B, 1C, and things like that. So the whole thing was dependent on the prognostic value of and survival statistics of lung cancer. Similarly, the pathological classification was also changed to minimal invasive, mucinous, non-mucinous, lipidic, and then micro alveolar, this thing, micro minimal, this thing, acinar thing, and then certain other thing, like the what do you call ground glass opacity, solid, and this thing. All these things came about only because of uh, prognostic value. Okay.
Okay. So in T3, in TNM7, it was more than 7 centimeters. In TNM8, it is T4. Then T3 atelectasis pneumonitis involving the whole lung in TNM7, it became T2 in TNM8 staging. Then in TNM7, T3 is tumor involving the main bronchus less than 2 centimeter distance to the carina. That became T2 irrespective of the distance in TNM8. Invasion of the diaphragm was T3 in 7th edition and it became T4 in 8th edition. In nodal, there is no changes. And in metastatic disease, M1B was distant metastasis. Now M1B became single extrathoracic metastasis and M1C became multiple extrathoracic metastasis. And so this is an image of regional lymph nodes. So mediastinal lymph nodes. So the numbers. So one is the red is one highest mediastinal, 2 shows upper paratracheal, 3 is prevascular and retrotracheal, 4 lower paratracheal including azygous nodes, 5 is subaortic, and 6 is para-aortic or ascending or phrenic, ascending aorta or phrenic. 7 is subcarinal lymph nodes, 8 paraesophageal below the carina, then 9 is pulmonary ligament. Then N1 nodes are hilar lymph nodes, interlobar, then lobar, segmental, and subsegmental nodes. This is the TNM8 staging, sir. So T and M are categorized together, and nodal disease is categorized separately. In the subcategory wise, T1A N0 is 1A1, T1B N0 is 1A2, and T1B 1C is 1A3. So T2A N0 is 1B, then T2B N0 is 2A stage. Then stage 2B is either T3 N0 or T1 T2 N1. Then stage 3A is either T4 N0 or T3 N2, T3 N1 or T1 T2 with N2 nodal involvement. Then stage 3B is T3 T4 with N2 lesions or T1 T2 with N3 lesions. Then stage 3 is T3 T4 lesions with N3 lesions. Then M1 is metastatic disease. So M1A, irrespective of involvement, is M1A and 1B irrespective of nodal disease is stage 4A and M1C is stage 4B. Now this is the proposed 9th edition of TNM classification of lung cancer. staging of lung cancer by radiographic techniques. Lesions can be reliably measured on chest radiograph and CT. Therefore, the differentiation between T1 lesions less than 3 centimeter and T2 lesions more than 3 centimeter is straightforward. Invasion of the visceral pleura, other criterion for upstaging to T2, is more difficult to recognize radiographically, but is rarely a criterion for operability. The same is true for associated atelectasis or obstructive pneumonia. This level of clinical staging, although not necessary in the decision to resect a given tumor, may be important for clinical trials of stage 1B, that is T2N0 tumors. This chest X-ray and CT demonstrate a 4 centimeter cavitary spiculated right upper lobe mass. Corresponding CT image in the center of this corresponding CT image also shows a 4 centimeter mass lesion and surrounded by ground glass opacity. Next, non-small cell cancers that contiguously invade the chest wall are potentially resectable. In a CT study by Glazer and co-workers that used various combinations of criteria for assessing parietal pleural or chest wall invasion, the sensitivity of chest wall invasion was 87% and specificity was 59%. It is interesting that although CT had limited predictive value, clinical symptoms of focal pain yielded a sensitivity of 67% and specificity of 94% for parietal pleural or chest wall invasion. Because surgical resection is the treatment of choice for tumors that abut locally and those that invade the chest wall, it is probably not critical for proper treatment to make radiological distinction between the two. So, this CT shows a chest wall. So this shows a superior sulcus tumor, sir. Hello. So this is a T3 disease with chest wall invasion. Chest radiograph demonstrates right upper lobe mass. Axial computer tomographic image identifies the lesion shown by the arrows. Details regarding chest wall involvement are limited. Before and after gadolinium enhancement of MRI, we can see that the MRI shows lobular protrusion of the mass into the apical right chest wall. Perhaps the most important distinction in terms of T status of a tumor is between T3 and T4, because the former stage 2B could be potentially resectable, whereas the later stage 3B should usually not be resected. In the absence of gross tumor invasion of the mediastinum or chest wall, these lesions present the greatest challenge because the distinction between tumor abutment and invasion of vital structures is often subtle. So this chest X-ray shows a T4 disease mediastinal invasion. Chest radiograph shows a chest radiograph shows a right hilar depicted by the arrows upper right mediastinal mass and an upper right mediastinal mass. There are also bilateral pleural effusions in this patient with non-small cell lung cancer. So it is the same patient with the CT image shows initial contrast enhanced CT shows the right mediastinal tumor mass with obliteration of the superior vena cava, focal luminal thrombus depicted by the arrowhead, and numerous iodinated contrast-filled collateral veins shown by the curved arrows owing to superior vena caval obstruction. Now, a contrast-enhanced CT scan after 6-minute delay illustrates clearing of the dense intravenous contrast from the collateral mediastinal vessels in this patient with mediastinal invasion. Determination of metastasis to mediastinal lymph nodes constitutes a critical point in staging and treatment recommendations. Mediastinal adenopathy or enlarged lymph nodes generally are defined as those with a maximal transverse diameter of more than 1 centimeter in their short axis. In patients with possible or proved lung cancer, the generally accepted threshold for suspecting metastatic nodal involvement is a lymph node more than 10 millimeter in size. Enlarged lymph nodes are by no means necessarily involved by metastatic disease. Sites of potential metastatic lymph node involvement in non-small cell lung cancer that are not usually addressed in the CT are supraclavicular and upper abdominal lymph nodes. Once they are palpable, supraclavicular lymph nodes are usually involved by metastatic disease in patients with lung cancer. Computed tomography has reported sensitivity for mediastinal lymph node assessment in non-small cell lung cancer between 57 and 79% with a positive predictive value of just 56%. No CT size criteria by itself are entirely reliable for the determination of mediastinal lymph node involvement. Now, this chest X-ray shows an N3 disease with ipsilateral hilar and subcarinal nodal disease. Large right hilar and subcarinal lymph nodes are present in this patient who also has malignant right pleural effusion. If mediastinal nodes more than 1 centimeter are identified, the patient should be evaluated further by FDG PET or biopsy. Specific imaging techniques such as combined FDG PET plus CT can identify nodal lesions as a target for endobronchial ultrasound, biopsy, cervical mediastinoscopy, esophageal ultrasound, VATS, etc. to optimize clinical staging. In areas of endemic granulomatous disease, enlarged lymph nodes can be found in even greater percentage of patients. So, this image shows N3 disease with supraclavicular lymph node, a CT of the primary left lower lobe lung cancer, then coronal plane PET CT of this patient with a left lung tumor shows abnormal left supraclavicular activity. CT shows the left supraclavicular lymph node that was overlooked at initial interpretation. Ultrasound guided needle sampling yielded metastatic adenocarcinoma in the supraclavicular lymph node. Patients with stage 1C tumors without enlarged nodes identified at CT mediastinal nodal metastasis. Invasive staging is not typically recommended for peripheral T1 lesions without enlarged mediastinal lymph nodes or FDG avid nodes. Despite combinations of CT chest, PET, FDG PET scans or integrated CT FDG PET, invasive staging is still recommended to confirm mediastinal nodal involvement. In a patient with early disease, normal sized mediastinal lymph nodes and no FDG avid mediastinal lymph nodes, resection with mediastinal lymph node dissection would be recommended. However, if the same patient has normal sized but FDG avid mediastinal lymph node, invasive staging would be recommended to complete the patient's clinical staging prior to treatment decisions. In patients with more central tumors, mediastinal lymph nodes with metastasis are more likely. In these patients or in patients being considered for pneumonectomy, invasive mediastinal staging is appropriate to validate the decision for resection. In all patients with small cell carcinoma considered for resection, extensive staging by diagnostic imaging, including FDG PET scan, is warranted. In addition, even with negative FDG PET scan, mediastinoscopy is warranted given the high incidence of occult mediastinal metastasis. PET CT. Principles of PET imaging. So, neoplastic cells require increased uptake of glucose. Furthermore, once the FDG is transported into the cells, it remains metabolically trapped after phosphorylation by hexokinase. Thus, the FDG accumulates within all cells requiring glucose, but will accumulate to a higher degree in highly metabolically active cells such as many lung tumors. This differentiation in glucose uptake is the basis behind the utility of PET imaging. Quantitative imaging regarding FDG uptake activity is obtained and serves as a measurement tool. PET is routinely performed in conjunction with CT, which allows for precise anatomic correlation between the FDG uptake activity and anatomic structures. Techniques and protocol for PET-CT. The main goals of patient preparation prior to PET are to limit physiological uptake of FDG radiotracer into normal tissues such as skeletal muscle. This will allow better detection of abnormal uptake within neoplastic disease. Patients should fast except water for at least 4 to 6 hours prior to imaging to decrease physiological glucose and insulin levels within the blood. Parenteral nutrition and intravenous fluids containing dextrose should also be stopped 4 to 6 for 4 to 6 hours. The blood glucose should be checked prior to administration of FDG radiotracer. If the blood glucose level is greater than 150 to 200 milligram per deciliter, the preferred method is to reschedule the test when the blood glucose level is under better control. Insulin may be given, however, administration of FDG must be delayed until serum insulin and blood glucose levels have reached equilibrium, which depends on the route and type of insulin administration. The patient should be quietly sitting or lying supine during the injection and uptake phase to minimize uptake in skeletal muscle and vocal cords. The patient should also be placed in a warm room prior to radiotracer administration to minimize brown fat uptake. The room should be quiet and dimly lit, especially for brain imaging. Usually, the patient should sit quietly and comfortably in the room for about 1 hour. Hydration allowing the patient to urinate prior to image acquisition, avoid high bladder activity, and allow better pelvic imaging. The patient must be able to tolerate the examination. Patient is required to lay still for the duration of the image acquisition, which ranges from 15 to 45 minutes. In addition, keeping the patient's arms overhead is preferred. History of claustrophobia must also be evaluated to assure the patient will be able to stay in the scanner for the required amount of time without moving. If the patient is able performing deep inspiration breath holds during the CT portion of the scan, study can greatly increase the accuracy of matching the PET images and low dose CT images. Now, limitations of PET CT are false positives and false negatives. So, false positive inflammatory is post surgical hematoma or biopsy, then post irradiation, post chemotherapy, local inflammatory disease, granulomatous fungal or mycobacterial, then thyroiditis, esophagitis, acute and chronic pancreatitis, acute cholangitis, osteomyelitis, lymphadenitis, recurrent fracture sites. Physiological false positive are salivary glands, brown fat, thymus, lactating breast or areola, skeletal and smooth muscle, esophagus, urinary tract structures, uterus during menses, corpus luteum cyst. False negatives due to technical reasons are small lesions less than 0.8 centimeters and misregistration. False negative physiological are low-grade tumors, bronchoalveolar carcinoma, carcinoids, metastasis to lung from mucinous carcinoma of breast and gastrointestinal tract, renal cell carcinoma, invasive ductal and lobular breast carcinoma. Now, this is the PET image, axial and sagittal and coronal images. The focal areas of increased FTG uptake within the lower neck and upper mediastinum. This is a classic example of brown fat FDG uptake. Treatment with benzodiazepines or warming the patient prior to scanning will decrease brown fat activity. PET with color overlaid on axial CT, which demonstrates localization of the fat FDG activity within the organs of fat in the neck, confirming the finding of brown fat. Coming to invasive staging includes CME, mediastinoscopy, scalene biopsy, thoracentesis, EBUS, and endoscopic ultrasound. Cervical mediastinoscopy (CME) is traditionally indicated in patients with otherwise operable non-small cell lung cancer with enlarged paratracheal or subcarinal lymph nodes, particularly if the cancer is proximal, if pneumonectomy is planned, or if patient is at increased risk for planned resection. CME has a negative predictive value above 90%, may be performed as an outpatient procedure, and is associated with low rate of significant complications. When pathological frozen section evaluation fails to demonstrate malignant nodal involvement by mediastinoscopy, resection may follow under the same anesthetic. The use of CME regardless of radiographic evidence of nodal involvement, that is routine mediastinoscopy, is not cost effective approach and adds little to the accuracy of staging in patients with adequate non-invasive preoperative evaluation. Mediastinoscopy is performed in the operating room under general anesthesia. A 3 centimeter incision is performed 2 centimeter above the suprasternal notch between the anterior borders of sternocleidomastoid. The superficial fascia of the neck platysma, investing layer of deep cervical fascia and pretracheal fascia must be dissected to reach the level of the trachea. Blunt dissection down to the anterior trachea allows entrance to the superior mediastinum. As the tract continues to be developed via blunt dissection, a tract into the superior mediastinum will develop between the anterior trachea and posterior to the great vessels. A mediastinoscope is then inserted and advanced along the tract, allowing for the sampling of lymph nodes and masses. So, patient position for mediastinoscopy with general anesthesia and endotracheal intubation. Shoulders are elevated and patient's head at the top of the table. Now, so, mediastinoscopy with small cervical neck incision. The incision is made just above the sternal notch and layers subcutaneous tissue, platysma, then investing layer and pretracheal fascia are divided to reach the trachea. This is a Carlen's mediastinoscope, and this is an image depicting the procedure. So, blunt dissection with the finger in the pretracheal fascia to reach the lymph nodes, sir. Then this is the image from the end. This is an endoscopic image of mediastinoscopy. Uh, the T denotes trachea and RMP is right mediastinal pleura and SVC is superior vena cava. Next. Complications of CME, innominate artery compression. When the mediastinoscope is inserted, it can cause compression of the innominate artery. This can lead to decrease in pulse oximeter signal and blood pressure when these are placed in the right upper extremity as a result of decreased blood flow to the extremity when the artery is compressed. Compression of the innominate artery can lead to intracerebral hypoperfusion, which can in turn lead to cerebral ischemia or stroke. Hemorrhage. Injury to the great vessels causes hemorrhage that can be life-threatening. An emergent thoracotomy or median sternotomy may be necessary to gain control of the hemorrhage while using the mediastinoscope to tamponade the site of bleeding. The procedure has a risk of air embolism given that the patient is in a head up position, reverse Trendelenburg, and the mediastinoscope can lead to vascular injury, which could lead to air entrained into the vascular system. This can be monitored via end-tidal CO2 and end-tidal nitrogen. Some recommend the use of precordial Doppler to monitor any venous air embolism. Airway injury. Instrumentation can lead to airway rupture. This complication requires an immediate thoracotomy. During the procedure, recurrent laryngeal nerve can be injured. The left is at more risk because it is because of its more caudal path under the aorta. Bilateral recurrent laryngeal nerve injury can lead to complete respiratory failure and the need to re-intubate and then perform a surgical airway of the patient. Damage to the thoracic duct can lead to chylothorax. So, extended cervical mediastinoscopy. So, the tunnel over the aortic arch is created to reach the aortopulmonary window with the standard mediastinoscope. So, extended cervical mediastinoscopy is used to approach the subaortic and prevascular nodes. Complications of mediastinoscopy: death less than 2.2%, major complications less than 1% are major hemorrhage intraoperatively, recurrent laryngeal nerve paralysis, cerebrovascular accidents, esophageal perforation, mediastinitis, mediastinal hemorrhage postoperatively, tracheobronchial injury, phrenic nerve paralysis, thoracic duct injury, venous air embolism. Minor complications, an incidence of 2.5%, pneumothorax, recurrent laryngeal nerve palsy, wound infection, minor bleeding, autonomic reflex bradycardia. The second is anterior mediastinotomy or Chamberlain's procedure.
How many
A
more
media-
slides do you have? It's already 8:45.
So,
We all
another
have to
20,
Huh?
more than 20, sir.
No, sorry, stop it. No, I don't think we can go on and on and on. See, these are all not clinical things. These are all theoretical things that you're talking about. So basically, you should have talked mainly about the different types of cancer, why there was a differentiation between small cell cancer and a non-small cell cancer. That is the basic thing. In small cell cancer, it is usually a systemic disease and surgery has a very minimal role, whereas non-small cell cancer has a major role with surgical management because of its prognosis. And in the early stage, non-small cell cancer have a better prognosis. And for that, when you have seen a lesion in the chest, you want to know whether it is benign or malignant. If it is malignant, whether it is localized, whether there are additional lymph nodes, what are the lymph node stations involved, and hence you stage the disease. And in stage 1 and stage 2, 2A, maybe sometimes 3A are amenable for surgery. The others are all chemoradiation, and these are all the things that you should quickly finish. This mediastinoscopy itself is a very huge topic, and I'm sure none of you have seen it. I used to do them much more frequently. Now that the EBUS has come in, we have the incidence of doing mediastinoscopy is very low. So this is all theoretical for you, and then you're going on and on and on about it. So basically, you have to know what type. Once you have seen a lesion in the chest, you want to know whether it's benign or malignant. Then what is the type of malignancy that it is? What is the type of cancer that is? And then the staging. And that decides your treatment plan, whether you're going to give them surgical management or medical management. I don't know whether you're going to talk about that decision making in the next class, but this is more than this thing. Okay, 8:45 already. Now you've gone more than 1.5 hours, and I think we can stop this. I know people cannot assimilate more than this. What do you say, sir?
Yeah. The only thing, the introduction could be better, because in an exam you're supposed to say, what's the frequency of carcinoma lung in men in women, in men probably prostate and the colorectal cancer cases, the carcinoma lung become 3 in women. And these are the usual, the examiners ask you. And women probably the breast cancer and skin cancer. And the other thing is most important, you didn't say anything about the etiology, smoking, importance of smoking, whether it is cigarette or cigar or pipe, secondary smoking, all these things usually they ask you during the exams. The asbestos, the importance of asbestos, the radon, the genetics importance, sometimes it's familial, all the etiological things of CLM, and the incidence of the small, didn't even mention any in there. It's small cell carcinoma of 15%, non-small cell 85%. Out of that, most common is the adenocarcinoma 40%, 25% of squamous cell and 10% large cell. All these things usually in the introduction it comes and you expect to see that. And previously one thing you missed, and I don't know whether they do that now because when you do a mediastinoscopy, your lymph node and the vein may look almost alike, You cannot go all around and see that's a rounded lymph node. So we used to say long needle and aspirate. I don't know whether that used to be a very important practical point they used to do before. I don't know whether such things are important.
It's up in the next slides.
And the other thing, next one, when you do that, it's very important in the recent days, the immunohistochemistry, the molecular testing, the genetic testing, and other things. So they know those things.
Yeah, the decision making. Basically, it is the decision making in lung cancer when you will intervene and when you will not intervene with surgical management. That is the whole thing. Unfortunately, Vijay was logged in, but he's left, I think. So we can't ask any this thing opinion from him. So basically, you see, pathology is very important in lung cancer. You just skip the whole thing. It's not proper. You have to know the etiology of the disease, as sir said very rightly. Which are the people who are prone for it? Not only smoking history, asbestos exposure, even some occupational things are also prone for lung cancers, and of course the genetic and all the other markers that have come about, which are make them prone for developing lung cancer. So that is important. The type of cancer is important, whether it is small cell or large cell, non-small cell. So because that depends on the treatment that you're going to give. And among the non-small cell, the various major factors. And of course, nowadays, there's a new classification. WHO classification is totally new. They don't no longer call it non-small cell, oat cell, large cell, bronchoalveolar. All those terminologies are gone. You must know, of course, you must know those as well, and also the newer terminology. But as I told you earlier, it is all meant for prognostic value. Okay.
Okay, sir.
Yeah, this became quite a bit of theoretical thing. So you have to understand why you're treating lung cancer, how you're going to pick them up first at early stage so that they are amenable for a good result, and then what is the treatment modalities that are available to you for treating lung cancer. This is the basic gist of the whole thing.
Okay, sir.
Okay.
Thanks.
Thank you.
Thank you, sir.
Thank you, sir.
Thank you.